I think we can start now. We're ready. So first of all, good morning. It's a great pleasure for me to be with you today for the first session on fertility preservation. And this session will be co-chaired with me by Francesca Gioia. And we are pleased to welcome all the speakers of this session. So first, Francesca, you will introduce the first speaker.
Hello, good morning everyone. So the first speaker of today, of this session, is Luciana Cacciottola, and she will talk about the role of apoptosis and autophagy in ovarian follicle pool decline from birth to late reproductive age and after gonadotoxic, they removed the role of apoptosis and autophagy in ovarian follicle pool decline from birth to late reproductive age and after gonadotoxic.
Thank you for the introduction. It's a pleasure to be here today to present you the late results of my work. First of all, I have no conflict of interest to disclose, and now we can start talking about the ovarian reserve, that as we know, it forms in the fetal life by huge mitosis rates of germ cells. Then there is a stabilization of those primordial follicles who complete their formation and are blocked at meiosis 1. And then there is a decrease through the life of women with a loss of around 85% of the follicle pool and remaining at the age of menopause with a residual follicle pool of around 1,000 follicles. The physiological mechanisms that govern this decrease over time are first the follicle atresia, so the physiological follicle loss of follicles at early stage over time, but also the activation for recruitment to end up every month in fertile life with the follicle, with the oocyte to ovulate. We know also that some gonadotoxic treatment like chemotherapy, for example, with alkylating agent, may change the slope of the follicle pool decline by resulting in a premature ovarian insufficiency. Two are the mechanisms that govern this cell death in follicles. One is apoptosis, that is a programmed cell death that can occur by activation of intrinsic pathway like a DNA damage, but also extrinsic triggers like cytokines and oxidative stress. And the other mechanism that is emerging as more and more crucial is autophagy, that literally means self-devouring, and is the mechanism by which cells renew their own organelle for either survival or when the damage is too massive for cell death as well. So the study question that we posed in our research institute is how does follicle loss occur physiologically and not from birth to adulthood, and what are the parameters that can affect it? This is relevant information because it may help us to develop strategies to protect the ovarian reserve from gonadotoxicity in the future. So we took 84 subjects. We included 84 subjects that underwent ovarian tissue cryopreservation in our hospital, Clinique Universitaire Saint-Luc in Brussels. The exclusion criteria was the presence of intraovarian pathologies, the ovarian metastasis already present at the time of cryopreservation, and also Turner syndrome. All these patients had a fragment of ovarian tissue fixed in anatomopathology department at the time of cryopreservation, and we used this fixed fragment to assess follicle density and classification, follicle apoptosis, and follicle autophagy. The patient characteristics are the following. 32 patients were premenarchal, while the other 52 were already postmenarchal, with different age range, of course. And the parameter we counted as to cross with the parameter of the follicle outcomes were, of course, age and menarchal status, but also presence of hormonal treatment and evidence of endometriosis at the time of cryopreservation in the post-pubertal group, of course, the presence of a cancer diagnosis, and the presence of some chemotherapy before cryopreservation. Looking at results, we start from age and the menarchal status, and we confirm that there is a progressive follicle loss through time, starting from a situation typical in a very young age in children of around 4 years of age, full of primordial follicle, to end up at the age of 30 years with a reduced primordial follicle pool, but also an increase in the growing follicles. Then also abnormal follicles decreased over time progressively, and as abnormal we counted follicles that had a double oocyte, that had very asymmetrical distribution of the granulosa layer, or had vacuolization in oocyte or granulosa cell without any other sign of atresia. Atretic follicle rates as well decreased over time without a difference in the slope. So that means that we're not more atretic follicle in proportion in any period of the lifespan we considered. The cell death mechanism were also assessed by immunohistochemistry, and we see that apoptosis rates didn't differ, like signs of initial apoptosis in follicles were not different in pre or after menarche, as well as autophagy activation. That means presence of some sparse autophagosome in the oocyte. There was no difference between groups, while the accumulation of autophagosome up to leading to cell death was 10 times higher in premenarchal patients. These results were further confirmed by transmission electron microscopy analysis that were done on a subgroup of patients, and again the accumulation of autophagosome, there are these with a double layer membrane, were found only in the prepubertal patient, premenarchal patient. Then looking at hormonal treatment and evidence of peritoneal endometriosis, no effect was observed in our cohort. And with looking at malignant and the diagnosis and the presence of chemotherapy, these are the results. In premenarchal patient, looking at all follicle outcomes we just talked about, the only differences were found in patients who had some previous chemotherapy compared to those who had a benign diagnosis or a cancer diagnosis but no chemotherapy before. Indeed, there were less abnormal follicle in those patients who had chemotherapy, and also more apoptotic follicles. While the story was a bit different in postmenarchal patients who indeed didn't have any difference in the apoptotic rates but had higher growing follicle rates after some chemotherapy compared to those who did have any chemotherapy. And also it's relevant to notice that there was an increase in autophagic activity by the presence of a cancer diagnosis itself, irrespective of some previous chemotherapy or not. So to conclude, we know that we confirm that for the age and menarchal status, there is a decrease in all follicle population with increase in age, and also that autophagy appears to be a crucial mechanism of follicle death before puberty. We assessed no difference in hormonal treatment and by the evidence in peritoneal endometriosis in our cohort. We found out that autophagy may have a role. There could be more autophagy activation in the presence of a cancer itself, but we still don't know. We will have to further investigate if this means a protective or a damaging role on the follicle reserve. And last but not least, that chemotherapy may have an effect that depends on age, being more towards clearing of abnormal damaged follicles with apoptosis mechanism in premenarchal patient, while being more towards an abnormal follicular activation in adulthood. Thank you for the attention.
Thank you very much. Do we have a question from the floor? Yep, you have to come to the mic, please. And we just need to know your name and where you... Okay, go first.
Hi, Monica Laranda from USA. Hi. I was just wondering, you said that you fixed the fragments. Is that the fragments that are released into the media during OTC processing, or was it a biopsy that was donated?
It was fixed at the time of biopsy, so it didn't go through cryopreservation protocol.
Okay, so but it was through the whole cortex and medulla?
Yeah, the cortex was taken by biopsy, a fragment taken together with the medulla. That is done especially in patients with a malignancy to assess if there is already cancer, like ovarian metastasis, but it's done before the whole process of cryopreservation.
Great, thank you.
Hello, my name is Julieta. I'm coming from Leiden, the Netherlands. Thank you for your presentation. I have a curiosity. So I saw that follicle that has this asymmetric growth of the granulosa cells, right? I've never seen this in tissue that has not been cultured, only after culture. So could you associate it with any condition of the patient? Have you seen more in a specific type of patient?
No, we don't have this data. In general, the rates in prepubertal patients were up to 10% of the follicle pool. In postpubertal patients were 2-3%. We find as well in other experiments in our research unit much increase of this feature after culture. But these were also described, for example, in the core study of Memsen et al. For comparison with the Turner syndrome patient compared to other prepubertal. So we check the same morphological parameter for that. But we find them in much lower percentages than after culture.
Indeed. Okay, thank you.
Okay, just one probably last question. What is the next step? And if you described that you had differences in terms of autophagy process after chemotherapy, especially in older patients, if I remember well, in younger, sorry.
Yes.
Okay, in younger. Do you think there will be an impact on this on the further transplantation or not?
More than in further transplantation, but maybe also in strategy as of gonadic protection during the chemotherapy. For example, there may be opening of a road to have more customized like development of strategy for a prepubertal patient compared to the other, as they seem to be more affected by apoptosis rates, while maybe some other development of strategy to decrease the ovarian follicle activation may be more useful for adult patients.
Okay. Thank you very much, Luciana. Thank you. So we can move to the next speaker, who is Hila Ranani. Hila, you will talk about safe and successful ovarian transplantation post-leukemia after combined various MRD excluding tests. So the floor is yours.
Thank you. I want to thank the eshre committee for letting us present our work about ovarian transplantation for leukemia patients. We have nothing to declare, and it's not something I'm doing wrong about moving the slides. Yeah.
This is to point, is the green to go further and this to go back, and this is to point.
Thank you. Yes, so nothing to declare. Ovarian tissue cryopreservation, OTCP, and subsequent ovarian autotransplantation, OTT, is a successful technique for fertility preservation for oncologic patients, mounting evidence by now published in literature of high implanted endocrine function and fecundity restoration, with more than 200 live births reported in the literature. In our recent publication, we show more than 90% endocrine function and 41% of live birth after at least one transplantation. So it's working. But since ovarian tissue transplantation is a unique situation in transplantation medicine, it's taken from ill donor to healthy recipient. concerns about cancer cell contamination of ovarian tissue collected at illness were raised in the literature from the beginning, and as published by Professor Meirov as early as 1996. And lately, two big good reviews summarized around 4% recurrence rate of malignancy in patients after ovarian transplantation. However, when investigated, relapse was not related to the ovarian tissue. So it's not moving. I'm pressing the right button. Can you help me? It's not moving. Thank you. So the probability of ovarian involvement is higher in several specific malignancies, and leukemia is considered high-risk malignancy for ovarian contamination. However, significant number of leukemia patients are prone to develop premature ovarian insufficiency and need fertility preservation due to alkylating agents exposure in ALL protocols or the need of ablating bone marrow transplantation protocols. Moreover, the urgency for immediate start, the poor health condition on presentation, and the prohibition of ART after recent chemotherapy exposure makes OTCP to be the only practical solution these days, especially for prepubertal girls. Therefore, in most fertility preservation centers, OTCP is performed for leukemia patients, but most centers avoid transplanting back due to risk of reintroducing malignancy. In our center, 750 women had gone through OTCP, 50% of them with hemato-oncology background, 12% of them with leukemia. In 2015 came the first post-leukemia patient with ovarian failure and desire for pregnancy. So to minimize risk of ovarian involvement and to enable safe transplantation, chemotherapy is initiated immediately at diagnosis. But if bone marrow transplantation is indicated, OTCP is performed at complete molecular remission to minimize leukemia colonization in the ovary. Thorough investigation of residual disease contamination is conducted later upon transplantation request. All our leukemia patients were exposed to chemotherapy prior to cryopreservation. As we published recently, results confirm that exposure to chemotherapy before OTCP does not compromise transplantation success rate, and this was shown also by other centers. Efforts are invested to develop techniques for bypassing ovarian transplantation and completely avoid risk of leukemic cell reimplantation. None of these techniques are proved practical yet. So MRD evaluations aim to search for presence of microscopic neoplastic cells in ovarian tissue. We evaluate presence of known molecular markers from tumor in thawed ovarian piece before approval of transplantation. But as histology has limited value, in order to increase MRD sensitivity, we combine several methods, NGS, PCR, immunohistochemistry, xenotransplantation into SCID mice, where 6 months post-transplantation we collect and investigated the original graft and several mice organs. In our center, 10% of patients who cryopreserved tissue came back for request of transplantation. Around 30% of them were leukemia survivors. So the aim of our study was to improve the safety of ovarian transplantation for leukemia patients. And our study included 21 leukemia frozen ovarian tissue evaluated for minimal residual disease. They were all exposed to chemotherapy, and they were divided to subgroups of leukemia, as you can see. So since 2013, we checked known leukemia molecular markers in stored ovaries. Hereby, we have 4 cases in which MRD marker was tested by PCR or myeloid sequencing panel. In all of these cases, molecular marker was not found in the ovaries. We did find nice pools of follicles in all ovaries. Additional 5 cases with known molecular markers at diagnosis were tested for MRD. 2 cases were found positive for MRD, one by PCR, one in the xenotransplantation model. Again, all tissues harbored very nice pool of follicles. 6 additional AML patients with unknown marker from diagnosis. We checked the original leukemia cell by myeloid sequencing panel, and in 3 cases we found molecular markers, but they were negative in the ovaries. So our AML group, you can see that in total we could give green light to most of the AML cases investigated. 2 patients were denied. 3 cases of ALL. In 1 patient, molecular marker was detected in the ovary by PCR, and 2 patients of CML evaluated for the presence of BCR-ABL. One of them was found positive in the ovary. To summarize, we had 4 patients with MRD involvement in the ovaries, as you can see in this table. But as you can also see that there was no one leading single test that revealed this in all 4 cases. So out of this group of 21 patients, 15 patients were found negative for MRD in the ovary and were approved to proceed for transplantation. 6 leukemia patients were transplanted so far, with 8 pregnancies and 6 live births. 5 patients were denied for transplantation. Leukemia patients need fertility restoration. Ovarian tissue transplantation should be considered for leukemia patients. Our study showed that most of investigated cases were negative for MRD and can proceed for transplantation. Combination of multiple techniques enhanced safety, since no specific test proved superiority. Important to save original leukemic cells for future evaluation if needed. And the xenograft, although it is time-consuming, significant for excluding, but not only the presence of malignant cells, but also their viability and aggressiveness. Our conclusions: leukemia survivors suffering from premature ovarian insufficiency can benefit from ovarian tissue transplantation. Most cases tested hereby were found negative for MRD and approved for transplantation. Following transplanted patients, our results show good success rate with no recurrence of leukemia. Patients with positive MRD who were denied for transplantation will be in need for alternative solution to restore fertility. I want to thank you for your listening.
So are there any questions from the floor? Yes, one.
Yes,
Okay.
I'm over here. Hi, my name is Lotte Kolmorn. I'm from Copenhagen, Denmark. And thank you for your lecture. I am interested in the follow-up in these challenging patients that we are all afraid of transplanting. So I would like to know how do you follow up? How long time do you have a follow-up, and do you recommend them to have the tissue removed again after they have had their children? Thank you.
So we can follow up as much as they want. We are a center that know these patients from diagnosis. Our first AML patient was transplanted in 2016. She had gone through 4 pregnancies, 3 children at home, and she even did another transplantation. It's because we are a tertiary center and they are followed by the oncologist. We are we see them like every few months. Whenever they need, they come. And it's now around 7 years from the first transplantation. And we do not recommend to take it out. We don't have this practice.
So Stine Christensen from Copenhagen also. So there's a French study in which they also look for MRD in both the cortex and the medulla. And sometimes they found positive markers in the medulla, but not in the cortex. So do you think we should also take medullary tissue and test, and not just the cortex and original tumor?
To take what tissue?
The medullary tissue.
We always do.
Okay.
On freezing. We check them at 2 checkpoints, on freezing and on thawing, both cortex and medulla.
Okay.
So we want to be completely sure.
Thank you so much.
Similar question. It's Melanie Davis from London. Thank you. Very thorough, nicely presented work. I think if I were a patient, I still decline to have the tissue back because you can't test the piece you're putting back in my body. And I wondered, you must have patients who have donated their tissue for research where you can do complete sampling. How representative do you think your results are?
So we all know that these tissue tested are representative and not the same tissue, and we all hope to be able one day to check the precise tissue that we will eventually transplant. We didn't thaw, as I recall, a whole ovary just to check how representative it is, but you have to remember that nowadays there is no other existing restoring fertility for these patients. We have patients that egg donation is religiously or culturally not an option for them. So sometimes after we do the thorough examination, we call them, we say, listen, as far as we know, we didn't find any evidence, but you need to know that there is a slight chance, we will never know. And they signed the informed consent, and we do it only after we have a broad, multidisciplinary decision.
Yeah, lovely.
And so
Thank you
far,
very much. Thanks.
Hello, thank you for the talk. Isabelle de Maistre from Brussels. I just wondering, I saw in the table that you use a panel gene for molecular assessment. Many well, some of the patients have no mutation detected with the panel gene. So you go back to the blood and test the full panel and validate a new gene, or you use other technique if the panel gene is negative?
The panel is consisted of 54 mutation that is specific for AML. So we test the ovary with it, not the peripheral blood. And also the original leukemia cells. And if we found in the original stored leukemia cells, then we go to the ovary and to try to exclude them. But we also combined all the other techniques that we have. As we showed, it's a combination of all of them together. Sometimes it took us like 15 months to evaluate before one transplantation.
Yes. But how many of patients have no molecular marker assessments actually in the list, and you consider that?
So I showed out of the 16 patients with AML, six didn't have a former marker, but 3 we were able to find. So we're left with 3 out of 16 that we didn't have any marker.
Okay, thank you very much. Thank you, Hila. Congratulations.
Okay, we can now pass to the next speaker, that is from remote, and it's Said Magassemi with the speak by the title Ex Vivo Photodynamic Therapy Approach using a nanovesicular photosensitizer to allow safe autotransplantation of ovarian tissue. I think there's some technical problem, and we see if we can fix them.
Sorry, I cannot start the video. I don't know how I can do it.
Sahed, can you hear us?
Yes.
Okay. Okay. Is it possible to start the presentation? It doesn't work?
What should I do? I don't know. There is no button to... I see the icon of the recorded video here in the right side of the screen, but it's not selectable.
Sorry, after now 2 years of webinar, we are still having some problems, it seems. Said we are trying to see with the technician here what we can do, okay?
Okay.
Okay, we can...
Good morning. First, I would like to thank the eshre Scientific Committee for giving me the opportunity to present the result of my work on fertility restoration in leukemia patients. As you saw by the title of my presentation, the goal of my study is to develop a photodynamic therapy approach to destroy cancer cells present in the ovarian tissue of leukemia patients without empowering the preantral follicle population. And how would that work? In summary, our idea is that once the ovarian tissue is collected from the patient, it can be incubated with a photosynthesizer, which can be photoactivated by light exposure. And this would lead to the formation of cytotoxic reactive oxygen species that destroy the cancer cell. After that, we could proceed with the routine procedure of freezing, thawing, and transplantation. To develop our PDT protocol, we divided the project into 4 experiments. First was to design and optimize a novel third-generation photosynthesizer. Then we determined the best PDT protocol to eliminate isolated leukemia cell in vitro. After what we assessed the ex vivo PDT efficiency using tumor model. And finally, we assessed the PDT innocuity to follicle using ovarian biopsies. Regarding to the first part of the project, we chose a non-porphyrin photosynthesizer called OR141 that can be photoactivated by daylight LED. And to induce more effective PS penetration, we are using a nanoparticle called neosomes, which are self-assembled colloidal drug delivery systems. So to purge the OR, prepare the OR-loaded neosome, I first optimized ORN formulation using mathematical modeling, and then we characterize our nanoparticle by assessing the release, stability, and morphology. Since I have only 10 minutes, I won't discuss this step. I just would like to say that the final ORN was around 300 nanometer and perfectly stable with the formation of an almost spherical shaped structure. Then we perform a study to determine the best PDT protocol to eliminate isolated leukemia cell in vitro. To this end, leukemia cell line and we isolated human ovarian stroma cell were incubated with different concentration of OR and ORN for 1 hour, and then exposed to the daylight, LED or not. After that, the cell post-incubated, post-PDT incubated for 24 hours, and the viability of cell was analyzed. A result demonstrate both OR and ORN are not toxic in the dark, as you can see by the blue line here, here, and here. However, when the PS was followed by the light exposure, we observe a significant decrease in the cell viability, as shown by the red line. And in the graph of IC50, we can see while OR showed a tendency to be more effective in eliminating the cancer cell, it significantly decreased the viability of a stroma cell compared to the ORN. This clearly shows that the selectivity of OR141 could be increased by our neosome formulation. After testing OR and ORN based PDT protocol on isolated cell, we wanted to know their efficiency in fragment of ovarian tissue, which is our final goal. Since ovarian tissue from leukemia patients is very precious, in our study we use a tumor model that represents the leukemia cell invasion in the ovary. We prepare the tumor model and divide them into 4 groups. These 2 groups are leukemia tumor model equated with OR and ORN, and these 2 are the same, but this time followed by light exposure. After this, the tissue was in vitro cultured for another 5 days and then fixed for analysis. The result confirmed that the OR and ORN are not toxic in dark, and on the other hand, in the light exposed OR and ORN treated group, the PDT procedure was able to induce apoptosis of leukemia cell, as we can see after CASPAS-3 staining, However, in the OR-PDT groups, some leukemia cells not only remain, but also continue proliferation. And moreover, and this proliferation is not observed in the ORN group. And in addition, in the lightest dose ORN treated tumor model, the HL60 cells were disintegrating as evidenced by the diffuse of brownish area in the CD43 staining due to this HL60 cell debris. So now that we saw that our PDTA protocol can destroy cancer cells without affecting ovarian cell, we must ensure that this protocol is not harmful to the follicle survival and development to be deemed a potential fertility restoration alternative. So for this, we divided the frozen told ovarian tissue fragment from healthy women at reproductive age into 3 groups. So the first is the pre-graft group, which are not xenografted tissues. And the second are control ovarian tissue graft, which was the fragment that we directly xenografted after thawing. And third is ORN graft group, where the tissue was treated by ORN-based PDT before transplantation. So after 7 days, the follicle population was assessed by histology and immunohistochemistry. As the result shows, no significant difference observed between the density and proportion of the control OT graft and ORN graft groups. And the follicle growth was confirmed by KCC7 positive granular cell, which was similar between these 2 groups. And it is also important to mention that none of the follicle after xenografting were positive for Cas+3. We also analyzed the ultrastructure of a pre-antral follicle in the pre-graft and ORN graft groups. As you can see, the majority of pre-graft follicles are at the primordial stage, while in the ORN group, only 90% of follicles were at the resting stage and 81% of them at the early growing stage. And as you can see here, the proportion of healthy looking follicle was similar between groups, which also indicate that our PDT approach does not negatively affect the ultrastructure of granular cell and oocytes. In conclusion, our PDT approach showed a high potential to purge leukemia cells from the human ovarian tissue. It can selectively destroy malignant cells. It doesn't have any impairing effect on the follicle survival, ultrastructure, and early development. And the outlook would be the long-term xenotransplantation studies to evaluate the PDT effect on a later stage on follicle development and oocyte quality. This is a study supported by grant from FMRS. I would like to thank my promoter and co-promoter, Professor Amorim and Professor Alfredo, for all their help and support. I thank Professor Tavon for providing the photosynthesizer and my wonderful colleague for their everyday positive energy. And thank you so much for your attention.
Okay, thank you very much. Let's see if there are questions from the audience. No. I have a quick question, actually. Are there any, have you analyzed the extracellular matrix? So, I mean, how is the environment after the treatment? Let's call it treatment.
Yes, that is a good question. Actually, that is a part of the study that I presented today. And due to the time limitation, I couldn't present all the results. So in the final step of this study, which is the in vivo result. We also did the analysis of fibrotic area of the tissue by mesentrechrome. And there is no significant difference between the group due to the about the tissue quality and the extracellular matrix and so on.
Okay, so it's really cell-specific.
Yes.
Okay, thank you.
You're welcome. Thank you.
Thank you very much. I think we do not have time for another question due to the technical problems. Say congratulations and thanks a lot.
Thank you so much for your attention. Thank you.
So we'll move on to the next speaker, who is Septami Nadesapillai. This work communication is selected for an award, and the title is Xenotransplantation of ovarian cortex tissue from young girls with Turner syndrome in mice model.
Yes, I do not see. Oh, now I see. Thank you for the introduction and the opportunity to present our outcomes on xenotransplantation of ovarian cortex tissue from young girls with Turner syndrome in a mice model. And this study was conducted in collaboration with UC Leuven in Brussels. And I have nothing to declare. Turner syndrome occurs in 1 out of 2,500 female live births, and it's caused by a partial or complete absence of one of both sex chromosomes. It is known that females with Turner syndrome have a shorter reproductive lifespan due to an accelerated loss of germ cells. And most females with Turner syndrome already reach menopause during childhood or early adolescence. Currently, ovarian tissue cryopreservation is the only fertility preservation option that can be performed at a young age while the ovaries are not yet active. Over the past decades, OTC has been successfully performed in young girls undergoing gonadotoxic cancer treatments. And OTC could be a promising technique for girls with Turner syndrome as well, by cryopreserving the pool of small follicles before the ovarian reserve is completely exhausted. In 2017, we have initiated a national intervention study in the Netherlands to identify which girls with Turner syndrome could benefit from OTC. In total, 100 girls with Turner syndrome, aged between 2 and 18 years old, were able to participate. And between 2018 and 2022, unilateral oophorectomy and cryopreservation of ovarian tissue was performed. And this study will continue until 2070, so that the follow-up of pregnancies of the youngest participants is completed. Currently, 89 girls had a unilateral oophorectomy, and follicles were found in 33% of the group, as you can see in blue. And we have mostly found follicles in girls who had a normal cell line present in lymphocytes or buccal cells. We have also found follicles in one girl in monosomic Turner, as you can see on the left. And girls with a structural aberration or 47XXX cell line were merged into the other karyotype group. Until now, very little is known about the karyotype of ovarian cells in girls with Turner syndrome. Well, this information is essential for understanding the mechanism of premature ovarian depletion. So as a first step, we determined the X chromosomal content of ovarian cells in girls with Turner syndrome with FISH analysis. And this analysis showed that most oocytes have a normal X chromosomal content, while granulosa cells are mainly 45X. And part of the stromal cells are also 45X, but some stromal cells also contain a normal cell line. In order to determine if aneuploid stromal cells and granulosa cells affect the follicular development of small follicles in this group, we used a mice model. Ovarian cortex tissue of 18 mosaic Turner syndrome patients, of which 7 were prepubertal and 11 pubertal, and 13 age-matched controls was used. And one part of the frozen thawed ovarian cortex tissue was grafted into a severe combined immunodeficient mice for 5 months. And the other part was used to analyze the follicles before grafting. During the last 2 weeks, we have performed ovarian stimulation by using 7.5 recombinant FSH daily. And after retrieval, we have analyzed the development of the follicles that were present in the grafted tissue. First, we used histology to determine the follicle density before and after grafting, and to analyze the follicle survival rate after grafting. We have seen that follicular development of small follicles in girls with Turner syndrome are capable of growing to secondary and even antral follicles, as you can see on these images. And on the right, you also see a follicle that is ovulated in a grafted tissue. On this slide, you see on the left the follicle density of girls with Turner syndrome in orange and controls in blue. And overall, the follicle density was lower in Turner syndrome patients before and after grafting. And in prepubertal girls, the follicular density was higher compared to the pubertal girls with Turner syndrome. And on the right, you see the follicle survival rate. And we have seen that the follicle survival rate of prepubertal girls with Turner syndrome was not significantly different compared to controls. While in the pubertal girls, the follicle survival rate was significantly lower in the Turner syndrome group. Secondly, we performed FISH analysis on the histological sections to determine the X chromosomal content of the granulosa cells in growing secondary and antral follicles in the grafted tissue. Centromere-specific probe for chromosome X and chromosome 18 was used as control. Chromosome X will be shown with a red signal, and chromosome 18 with green. In a normal granulosa cell, you would expect to see 2 hybridization signals for both chromosomes. So you would see 2 red signals for chromosome X and 2 signals for chromosome 18. But in case of a 45X granulosa cell, you would expect to only see 1 red signal for chromosome X, but you would still see 2 signals for chromosome 18. In this figure, you see the secondary and antral follicles with the DAPI staining. And below, you see the results of the FISH analysis. On image E and image G, the amount of red signals for chromosome X and the green signals for chromosome 18 were similar to each other, which indicates that the granulosa cells had a normal X chromosomal content. In contrast, on image F, there were more signals for chromosome X, which is shown in red, compared to the green signals of chromosome 18, which indicates that the granulosa cells had an extra X chromosome, which is indicative for a 47 triple X cell line. And in contrast, on image H, you see that there are more green signals for chromosome 18 than red signals for chromosome X, which indicates that the granulosa cells have lost one of their X chromosome, which is indicative for the 45X karyotype. And during folliculogenesis, we have seen a decline of 45X granulosa cells. On this image, you see the results of patient A and B as an example. And here on the left, you see the granulosa cells of small follicles from non-grafted tissue. And each bar represents a follicle with multiple granulosa cells. And as you can see, most granulosa cells had a 45X karyotype, which is shown in black. And on the right, you see the granulosa cells of secondary and antral follicles in grafted tissue. And a remarkable shift from high to low percentage 45X granulosa cells was observed. And we have also seen different level of mosaicism between patients, but also between follicles of the same patients. And finally, we have performed immunohistology and immunofluorescence to analyze several key proteins that are essential for the folliculogenesis. First, we have pCNA and AMH, which were analyzed to examine the granulosa cell function. We have also examined BMP15, GDF9, c-KIT, and KIT ligand to evaluate the interaction between oocyte and granulosa cells. And in the next slides, I will present the results of AMH, BMP15, and c-KIT as an example. On the left, you see the expression of AMH, and next to it, you see the results of the prepubertal girls with Turner syndrome in orange, and again in blue, the controls, before and after grafting. And on the right, you see the results of the prepubertal girls. And we have seen that the expression of AMH, which is a marker for the ovarian reserve, was similar between girls with Turner syndrome and controls in the prepubertal group. While in the pubertal group, we have seen that the AMH expression was lower before grafting in the Turner syndrome patients. But after grafting, the AMH expression also increased in that group, which made it similar in Turner syndrome patients and controls. And these findings were also seen for GDF9 and KIT ligand. Next, c-KIT, which is expressed by the oocytes. And we have seen that the expression of c-KIT before and after grafting in prepubertal girls with Turner syndrome and controls was not significantly different. And in the pubertal group, we have seen that after grafting, the expression of c-KIT in Turner syndrome patients was significantly lower. And finally, BMP15, which is a marker for the proliferating marker and is expressed by the oocytes. And we have seen that in Turner syndrome patients, BMP15 was significantly lower before grafting. And after grafting, BMP15 increased in both groups, and in prepubertal girls, there was no significant difference anymore. While in the pubertal group, the BMP15 expression also increased, but it remained significantly lower compared to controls. So in conclusion, small follicles of Turner syndrome patients are able to grow to secondary and antral follicles, despite the presence of aneuploid granulosa cells and stromal cells. A decline of 45 X-granulosa cells was observed during folliculogenesis. And we have found a reduced expression of c-KIT receptor and BMP15 after grafting in the pubertal girls with Turner syndrome. However, we have seen normal follicular development, so the question remains if these findings also have functional consequences. And after this presentation, I hope you will remember that OTC could still be a realistic option for girls with Turner syndrome if sufficient numbers of follicles are present. And I would like to thank the team of UC Leuven and especially Professor Dolmans, Professor Dornay and Dr. Nguyen for their collaboration. And I would like to thank the other members of the Turner fertility team and the participants for making the study possible. Thank you for your attention.
Thank you very much. Other questions from the floor?
Thank you very much. It was a great talk. I enjoyed it a lot. I have a question about AMH. I'm from Turkey. I'm a histology and embryology professor in Turkey. So what do you comment about the AMH increase after the transplantation? I mean, were you able to correlate them with the mosaicism and the AMH level?
Well, what we have seen before grafting in pubertal girls, that the AMH expression was lower. And what I didn't show in this presentation was that we also looked at the abnormal follicles before and after grafting. And before grafting, the amount of abnormal follicles in Turner patients was almost 3 times higher compared to controls. But after grafting, it was similar to controls. So I think there is a selection of the abnormal follicles that had apoptosis, and that the normal follicles will develop. So that's just like a selection in these of the good follicles to grow further.
Thank you very much. And were you able to look at the reserve then? AMH, if it would increase, were you able to look at the residual ones?
Sorry, I don't.
I mean, when the AMH increases,
yes.
So there will be like the residual ones, the pool would be better.
Better, yes.
Yes, were you able to check that?
No, yeah, I think the most optimal outcome of this procedure was that we've seen an ovulated follicle in the grafted tissue. So it means that it has completed the whole procedure. But yeah, the next step is if it gets fertilized, and that's something we can do with this.
Thank you very much. Thank you.
Yes, thank you so much. That was absolutely beautifully presented.
Thank you.
And an incredible amount of work. Fascinating data on aneuploidy in the granulosa cells reducing during development. Mm-hmm. The only concern I have, a bit of a challenge, is your conclusion that OTC is a valid option for the girls with Turners, because I don't think we can say that without looking at the natural history of the condition.
Yes.
And I suspect that very few of these young women will come back to have the tissue replaced because they were retaining natural fertility.
Yes, so for this procedure we were also a little nervous because another outcome could also be that there was no follicles present after grafting. So we know with our study that the follicles will grow and develop to secondary and antral follicles despite the presence of the aneuploid granulosa cells and stromal cells. But if you really want to be sure, as you say, we need a Turner syndrome patient who gets pregnant with this procedure. And then we know that it's really a valid option. And my message for today is that it still could be a realistic option, but we have to be sure.
But there's still a lot of young women who've gone through invasive surgery to have the grafts taken.
Yeah.
Yes, so a bit of a shot in the dark, really, when the study was set up.
Yes, yes, that's correct.
Last question, Klaus.
Thank you very much for this very nice presentation. I'm Klaus Jyling Andersen from Copenhagen. I wondered, you mentioned to us that the number of follicles that did not express BMP15 in the Turner syndrome patient group was around 40. So this means that 60% of the oocytes do not express BMP15.
Yes.
Is that a worry? I mean, I would expect that this is something which really do need to come on in an oocyte.
Yes.
And as far as I understand, BMP15 is only coming on when the follicle starts to grow. So it'll only come on in the secondary or sort of when the follicle has embarked on.
Yes.
So how do you think that this would affect your conclusions?
Well, with the BMP50, it's correct that it's all namely expressed by the oocytes, but there is a close signal pathway between oocytes, granulosa cells, and also the stromal cells. So it could be that the aneuploidy of maybe the stromal cells could influence also the expression of BMP15, but I can't give you a 100% sure answer because this is something that we have to analyze further.
Okay.
Okay, thank you very much. So we can now introduce Stine Kirstensen, and she will talk about revascularization of human ovarian grafts occurs equally efficient from both sides of the cortex tissue. Implication for
clinical practice. Thank you. So, hello everyone, and thank you very much for the introduction, and thank you very much for the organizing committee for giving this opportunity to present our work here at the annual meeting. Thank you so much. I have no conflicts of interest. So, as Hila pointed out, then ovarian tissue cryopreservation does indeed work, and also transplantation. We know it works with the new data, and it is a valid method to preserve fertility in these young girls and women. And I think we all can all agree that we do the preparation and the freezing. We can do that very well. We have shown that now in many studies. And a few years ago, we showed in the Danish cohort that we have an average of 84% of the follicles surviving the whole preparation, the freezing, and thawing. So I think this part, we can agree we do pretty well. But where we really lose the follicles are when we transplant the tissue back, because we have a long period of hypoxia, and then we have the ischemia and the reperfusion injury, where we lose a lot of the follicles. So we know that less than 30% of the follicles actually survive the transplantation and grafting. So this is a very critical point, and this is something David Baird already showed in the 90s, and this also showed that we have this very low survival of the follicles. So a very critical point with the grafting. And despite that, then there's actually not a lot of consensus as to how and where to transplant the tissue. And this is a map showing all the countries and centers which has now transplanted tissue worldwide. So you can see a lot of countries has established this technique. But there's also a lot of different ways of transplanting the tissue back. And this is some examples. So in the US, Sherman Silber, he decorticated the ovary. And then he put the thawed tissue on top of the medulla, and then he sutured it to the medulla. In Brussels, this is Jacques Nunez's technique he developed in 2004. They used the interseed or fibrin glue to also adhere these cortical tissues on top of a decorticated ovary. In Germany, they transplant to these peritoneal pockets, and they believe that this is a good site for revascularization, and you can see just the pieces of tissue here in the bottom of the pocket. In Denmark, we transplant to the ovary, but also peritoneal pockets, and we put it into these subcortical pockets. In Australia, they actually both do the cortical pockets, the peritoneal pockets, but also the abdominal pockets. And here you can see they have put the tissue on this string, and then they pull it through this channel in the abdominal wall. So there's a lot of different ways to do this. And as you also know, all of these centers has also produced live births, so it works no matter how we do it. But I think we still miss a lot of data to show if there's any superiority of any of these techniques. So that's, of course, difficult to compare these techniques directly. So one of the first questions we wanted to ask was regarding the graft. So we know this, you can see here, this is a piece of tissue that we have thawed and stained with neutral red. So all the red dots are the small follicles, viable follicles within the cortex. But what we also know about the cortex is that it's covered by this very condensed and fibrous tissue, the tunica albuginea. And this is really hard. You can see it here just on top of the follicles. So the big question is this fibrous tissue a barrier for the neovascularization when we transplant? Because we guess from the medullary side we'll get some access from the vessels, but is then this fibrous tissue any kind of barrier for this process? So we did a very simple setup. We thawed 2 pieces of tissue from 12 women who had donated the tissue for research. We transplanted to immune deficient mice in these subcutaneous pockets. And then we had 2 arms. After 8 days, we retrieved the graft and did this immunohistochemical stainings for the murine CD31 to quantify vessel density and vessel area. And then in the second arm, we did 8 weeks of grafting to do the follicle survival. And here you can see the immunohistochemical staining with the CD31. So in this setting, we had priority to orientate the graft during the sectioning. So we did a transectional sectioning. So you can see here the cortical side of the graft turning outwards, and then the medullary side towards the medulla part of the ovary. And then we had this app developed in collaboration with Visiopharm. And here you can see we have defined the whole graft by the green line, and then it has identified the positive CD31 staining. And what we could also do with this app, we could subdivide the vessels into different sizes. So we have the micro vessels here in blue, and the yellow ones are the small vessels, and then the orange ones are the large vessels. And then finally, we could also do these defined regions of interest with the cortical region turning outwards, the center, and then the medullary side turning inwards. And here are the results. There we get it. Yeah, and here you can see the distribution of the different sizes of vessels. And as you can see, the vast majority are these microvessels. And we would expect that because it is a new vascularization in these grafts. And it's the same in all 3 regions of interest. And we were also able to do these heat maps. And here you can see the different representative images from the different graphs from all the 12 patients. And it's just to show you that it really varies a lot how this tissue is actually vascularized. And you can see it comes from all sides, I think primarily in the periphery of the grafts, but still some areas are not vascularized and sometimes it's completely vascularized. So it's very individual for each of the grafts. And when we look at the quantification, then we also see a clear pattern here that when we look at the area, the percentage of CD31 positive cells, then you can see that in the cortical side and the medullary side, we have around 4% area, whereas in the center, it's a little less. And it's the same that we see when we do the quantifications of vessels with the vessel density. We have similar levels of number of vessels in both the cortical and medullary regions, and then we have significantly fewer in the center. So this really highlights that it doesn't seem that this cortex is a barrier for any vascularization. We have equal amounts coming from both the cortical and medullary side. So what kind of implications can we then say this could have in clinical practice? And here I want to highlight that like some of these techniques, when you do the decortication and then put the cortex on top, this is a way to mimic the ovary, and it makes sense. You want to mimic the ovary with the medulla inside and then cortex on top. But again, then we only have vascularization from the medullary side. So you don't have any vascularization from the cortical side. Whereas when we look at the techniques where we put the tissue into pockets, then we actually have vascularization from both the cortical and medullary sides, as you can see here in both the ovarian sides, the peritoneal sides, and the abdominal sides. Then in these channels, then the tissue is covered by tissue on both sides. So we suggest that when you use these techniques where you ensure ingrowth of vessels from both sides of the graft, this could potentially get faster vascularization because you kind of half the way throughout the graft when you have vascularization from both sides. So potentially these techniques could have a better way of supplying the graft, and we could have better survival of the follicles because we have a reduced ischemic period. But again, we were not able to show this in this study, and we didn't design it to compare the different techniques. But this is, of course, what we need to try and do now, maybe in large animal models, try out these different techniques and see if we can actually see this concept where we have vascularization from both sides, giving a better survival. Yeah. And to that, I also have to say that, yeah, it could be a big difference, but when we look at all the reproductive outcomes from all the centers, then they're very comparable. So I cannot say that this is something that's going to be a game changer, because it's probably not, because we see all the centers having a similar live birth rate of 20 to 30% in their cohorts. So, and we also know a lot of these centers use different cryoprotectants and different sites and different techniques, still have the same outcomes. So maybe it doesn't matter that much. But I still think it's worth looking into and see if we can optimize any of this to have more surviving follicles. So take-home messages. I didn't have to go through the follicle data, have time for that, but we also saw an average survival of 28% follicle survival, and this is exactly the same as David Baird showed 30 years ago, so that's not new. But these data with the revascularization is new, that we have vascularization from both sides. The cortex is not any barrier for the new vascularization, and it could be something that could affect follicle survival and give a better vascularization if we find a good grafting site where we can have the vascularization from both sides. So it's just worth looking into when we talk about grafting sites, definitely. But we do need to do these direct comparisons in large animal studies. So if you want to read the paper, you can download it online from RBM Online. And I just want to finish by thanking my wonderful colleagues in Denmark. And thank you very much for your attention. Yeah, Monica.
Thank you, Steen, for the great talk. Yeah.
Hi, a very interesting talk, and I agree with you that getting into the weeds of some of these different ways to transplant, I think might improve collectively the transplantation rate. I wonder if you looked at either mural cells or parasite markers to see the potential or patency of the vessels, while there's like CD31 positive endothelial cells there, the extent of the vascularization and maybe patency of the vessel itself might be important.
Yeah, no, we didn't, Monica, but we would love to. And I think this is a way where this is something we need to go a lot more into and have more markers and look at it in a different way. Yeah, I agree. But we didn't. Yeah, sorry, we didn't do more. No.
Hi, very good talk. Thank you. Interesting knowledge. I think when we transplant a tissue, we induce there. This is an induction. In general, the cortical follicles, I mean the primordial follicles are far away from the blood. We don't, I mean in physiology.
Yeah.
But we induce here with the transplantation. And then both sides start to vascularize to nourish the area. But then the follicles are activated. Maybe that's the problem. Can you make a comment on that? I mean, that angiogenesis is the problem, maybe.
Yeah. No, but you're right. So that's different mechanisms causing this follicle loss. So as you say, it can be many things. But I think here it's mainly to save the graft. It's not the follicles, as you say. They are used to being under hypoxic conditions, but it's really to save the graft and the environment for the follicles, where I think the revascularization is very, very important. But as you say, it can also be the whole activation that we need to look more into.
Yeah,
but,
thank you
but
very
that's
much.
different mechanism.
Thank you.
Yeah.
Hi, Susanna Williams, University of Oxford in the UK. Stina, super talk. Thank you very much. It just still strikes me, obviously now you've got the vascularization from both sides. That seems really interesting and important. And you did a comparison with different places around the world, saying that they still had a similar number of children that were coming out. But I was thinking, if it's talking about follicle survival, wouldn't it be duration of graft potentially and how long it's survived that might be the measure there?
Yeah.
But I do appreciate that everyone is doing something different, but is there something we can get out of this? There's a lot of data now.
Yeah, and I completely agree. We need to look more into these single centers and then comparing the technique with some of these outcomes. But right now, I think the most recent papers, they have like accumulated the data, and then they can show something about the graft duration and stuff. But we need to go into these subgroups and then compare the technique. And yeah, I think it's actually a better endpoint to look at the duration of the grafts, actually, as you say. It's a more direct way to see if we have more follicles surviving, sustaining the ovarian function for longer. Yeah, that's a good point.
Yeah, because 28% is rubbish. We've got to do better. Thanks very much.
Thank you.
Last question.
Helen Picton, University of Leeds, UK. Thank you, Stina. It was a beautiful talk. I wonder whether you'd had the opportunity, perhaps it's too soon, to look at the effect of age and follicle loading in the grafts, because the quantity and quality of the cortex, as you just mentioned in one of your previous questions, is critically important to the survival of the follicles in the graft post-thaw at any time in the ovary. So if we've got densely packed follicles or thinly distributed follicles, for example, after exposure to chemotherapy when we freeze, would you expect to see a difference in the speed of revascularization of tissue or not? You thought about that?
I think that's one of the theories. Excellent point, Ellen. And I think this is why we actually need to extend this study, so we can actually try and answer these questions, because we do think that the more follicles, the better it is to attract vascularization also. So there's factors within the tissue that can affect the revascularization. So yes, that would be beautiful if we could extend these studies with this kind of add-on. Good point. Thank you.
Thank you, Sten, for the great talk. Congratulations.
Thank you, sir.
We just now have to move to the last speaker of the session, who is Laura Lotz. And it's another presentation pre-selected for award on ovarian tissue transplantation in 196 women by FertilProtect, the live birth rate of 26.5% per woman.
Thank you very much for the introduction. Dear ladies and gentlemen, the topic of my presentation is ovarian tissue transplantation in 196 women by FertilProtect. Live birth rate of 26.5% of women is associated with female age and first versus repeated transplantation. I have no conflict of interest. Ovarian tissue freezing and transplantation has been included in numerous recommendations and guidelines as an established method, but one that needs improvement. The live birth rate after ovarian tissue transplantation has been reported to rank from about 24 to 41% per patient. However, data on success rates, transplantation technique, and factors associated with transplantation remains limited. And these limitations make it difficult to establish reliable indications in, for example, cases where oocyte freezing is also a viable option. Therefore, the aim of this study was to evaluate the outcome of ovarian tissue transplantation regarding pregnancy and live birth rates performed in the FertilProtect network, where many centers are involved in transplantation, and to define factors associated with pregnancy and live birth rates, such as female age, first and repeated transplantation, or experience of the transplanting center. FertilProtect is a network founded in 2006 as an association of 158 university and non-university reproductive medicine centers in Germany, Austria, and Switzerland. It runs a registry which data is published on an annual basis in a national and international report of the German IVF registry. From 2007 up to the end of 2019, a total of 244 ovarian tissue transplantation had been carried out in 196 women. So ovarian tissue transplantation were evaluated until the end of 2020 to allow a follow-up of at least 12 months after transplantations. And the transplantations were carried out in 26 centers of the FertilProtect network. From the 196 women, 64 got pregnant, representing a clinical pregnancy rate per patient of 32.7. And 52 gave birth, corresponding to a live birth rate per patient of 26.5%. In total, 244 transplantations were performed and 18 pregnancies were achieved. Among the women who became pregnant, pregnancy was achieved by IVF in 38.3%, and 61.7% of pregnancy were achieved after spontaneous conception. The mean age at the time of cryopreservation was 31.3 years, and it ranks from 70 to 44 years. And the age at transplantation, the mean age was 35.9 years, ranging from 23 to 46 years. And the patients who became pregnant after the first transplantations were younger at the date of cryopreservation, with a mean age of 29.9 years, compared to those patients without a pregnancy with a mean age of 31.9 years. And both patients group also differ regarding the age at the time of transplantation. In this figure, you can see the live birth rate as a continuous function of age at cryopreservation with a pointwise 95% confidential interval based on a logistic regression analysis. And the estimated pregnancy rate was 40% at the age of 21, representing the 5th percentile of our study population. And it was 15.7% at the age of 39, representing the 95th percentile of the study population. After the first transplantation, from the 196 women, 60 got pregnant, representing a clinical pregnancy rate of 30.6% after first transplantation, and 49 gave birth, representing a live birth after first transplantation of 25%. 43 women underwent repeated transplantation, 39 underwent a second transplantation, and 4 patients even a third transplantation. From these 43 patients, 9 had already got pregnant after the first transplantation. And after repeated transplantation, 55.5% got pregnant again, and 44.5% had a live birth. From the 43, however, 34 had not got pregnant after first transplantation, and after repeated transplantation, only 4 got pregnant after repeated transplantation, representing a pregnancy rate of only 11.8% and a live birth rate of 8.8%. The ovarian tissue transplantations were carried out in 26 centers, and the total number of transplantations performed per centers varied between 1 and 100 transplantations, and the number of patients between 1 and 82, with a median of 2 and a mode of 1. And in the figure, you can see the mean clinical pregnancy rate relative to center size defined by the number of ovarian tissue transplantation. And the figure indicates that the pregnancy or the live pregnancy rate increase with the size of the center. In this study, we had analyzed a large number of transplantations, and the transplantations were performed within a network with the same standards regarding tissue freezing, transportation, and transplantation. It reflects a real-life scenario in a country where many centers are involved in tissue freezing and transplantation. However, the weakness of the study is its retrospective design in the context of a retrospective analysis and the heterogeneity of the data due to the large number of centers. Moreover, data such as ovarian reserve and premature ovarian failure was not available for all women, and the data might be biased, influenced by the different follow-up policies of the centers. In conclusion, the study confirms that ovarian tissue freezing and transplantation is a realistic option for young women, with at least 1 in 4 transplanted women achieving a live birth. And the success rate was significantly related to the age of the woman at the time of tissue freezing. The success rates tended to be higher in centers with experience in ovarian tissue transplantation, and the success rate were low for repeated transplantation when pregnancy did not occur after the first transplantation. Therefore, the study opens the discussion on whether transplantations would rather be performed by experienced center, and suggests that it's better to focus on the first rather than the repeated transplantation. And even when ovarian tissue freezing and transplantation is always an established method, there's still place to improve the outcome by optimizing the indications, logistic, and surgical techniques. Finally, I would like to thank my co-authors from Germany, Austria, and Switzerland, and I want to thank you for your attention. Thank you very much.
Thanks a lot, Laura. Any comments?
Yep, sure.
Thank you for your presentation. I wouldn't ask a question about this ovarian transplantation. How we calculate the risk of that we get to increase the risk of tumors after knowing that it would be a new vascularization? Does increase that the risk for another tumor in human with malign tumors if we do this transplantation of ovarian tissue?
Can you repeat?
Does we have a higher risk to have another tumor?
With the recurrence, we had no recurrence cases reported within the Ferti Project network from the patients we have analyzed.
Okay, thank you.
Thank you, Kate Stone from Melbourne. That was fantastic. The power of having big numbers is great. Do you have any data on implantation rates in your IVF conceived population? You said 31% were by IVF. Do you have implantation rates from that?
We have the pregnancy rate after IVF, yes, but because of the registry analysis, I cannot give a special pregnancy rate for IVF. I can only say that after the pregnancy, the women who had got pregnant, over 60% had spontaneous conception, and 13 had IVF. And I know that about 40 patients, women, underwent IVF, and over 50 of them got pregnant.
Hi, thank you for excellent talk and amazing work. I'm Julia Kapika, London. Did you look at the time to pregnancy, and did you have any cases where people had 2 babies possibly from one transplant?
No, we did not look for the time of pregnancy, unfortunately. Yes, that's a good point.
Yeah, because I noticed we do like to look at the problem as how many babies born. But if you look even in natural conception, you don't expect everyone to get pregnant within 1 year. So for a certain age group, you'll say you expect 80% pregnancy rate within 1 year for someone under 35. So it would be nice to look for this group of patients and say, yeah, it was 40%, but over what period of time? So it's quite useful tool even for counseling our patients, I think.
Yes, that's all right.
Nathalie Rive, Rouen University Hospital, thank you for your talk. If I have well understand what you mean, you have performed ovarian tissue cryopreservation in patients aged more than 35 years, and you have grafting the tissue from this patient. And considering your conclusion, did you recommend to maintain ovarian tissue cryopreservation for such patients aged more than 35 years?
Sorry, I don't understand.
It seems that you you took ovarian tissue from relatively aged patient older than 35, and do you still recommend, given your result, a transplantation in such patients?
Yes, we do not recommend it to take ovarian tissue over the age of 35 years, but in some specialized group, after education of the limited results, we also cryopreservate ovarian tissue in our group.
Thank you.
Okay, last one.
Hi, Nana Chandran from UK. One of the limitations is in ovarian harvesting and time to freeze the laboratory facilities available for the hospitals. You have got so many hospitals. What is the average time from time to harvesting the ovarian tissue to freeze or slow freezing of the ovarian tissue taken?
So it depends on the hospital. Some hospitals have the possibility to freeze directly after surgery. And sometimes, especially in Germany, hospitals send the ovarian tissue, transport it over a time frame of 24 hours in an institution for freezing.
So you are accepting around 12 to 24 hours in normal saline, normal temperature, or 4 degree?
No, on ice, on 4 degree. When the transportation, when we transport ovarian tissue, it's normally sent on at 4 degree.
4 degree?
Yes.
Okay.
And transport box, yes.
Okay, thank you very much. So.